A very good morning to our vitreoretina fellow colleagues in Indonesia. I'm Tock Han Lim from Singapore. It's indeed my pleasure and my honor to share with you some updates on polypoidal choroidal vasculopathy. So let's start the screen sharing. These are my financial disclosures. PCV may present with a myriad of clinical presentation, not just in serosegmenous maculopathy. But the hallmark of diagnosis of PCV is the presence of typical nodular ICG hyperfluorescence, as in this case of peripapillary PCV. PCV is a lot more common among Asian patients. As you can see, about one in three of our patients with exudative AMD would have PCV. PCV is best imaged by confocal scanning laser ophthalmoscopic ICGA. Now this differs from flash ICGA, which is very capable of imaging the nodular hyperfluorescence, but not as good for the imaging of branching vascular network. This is what the CSLO ICGA can show us about the branching vascular network. If you look at flash ICGA, you can't really see the BVN, but if you look carefully, it is actually there. Now, imaging PCV with CSLO ICG allow us to appreciate that the condition is a bicomponent disease consisting of a branching vascular network and polypoidal lesions. Leakage can come either from the polypoidal lesions or from the branching vascular network, or both. Co-locating ICGA with OCT gives us even further information. Now, co-locating the branching vascular network with OCT tells us that there is hyperreflectivity between the RPE and Brooks membrane, similar to type 1 CNV. Co-locating the polypoidal lesion with OCT shows us that there is peaked PED with hyperreflectivity between RPE and Brooks membrane. Another example, co-locating the image with OCT shows us that there is actually round-shaped hyperreflectivity. And in this case, round-shaped hyperreflectivity with a lumen, both occurring between the RPE and the Brooks membrane. Hence, multimodal imaging, co-locating ICGA with OCT is very important for the diagnosis of PCV and also for the differential diagnosis of this condition. Why so? Several conditions can show nodular hyperfluorescence on ICG, but they are not PCV. In this condition, the top four, if you co-locate with OCTA, it will co-locate to hyperreflectivity above RPE, not below RPE. As in this case, looks like PCV, but OCT co-location tells us that hyperreflectivity right here is above the RPE and is intraretinal. This is a case of RAP, not PCV. It's another case, it looks exactly like a PCV. If you co-locate it with OCT, you can see that the hyperreflectivity is above the RPE. This is a type 2 CNV and not PCV. Another case that is shown with OCTA, you can see that OCTA can diagnose branching vascular network very clearly, now co-locating with the ICGA. And in this particular case, you can see the polypoidal lesions also show up in OCTA. However, while OCTA is able to image 90% or more of branching vascular network, it is not as effective or accurate in the imaging of polypoidal lesion. As in this case, you can see a very clear polypoidal lesions on ICGA, but not on OCTA. Another issue with OCTA today is segmentation error. This is a case which shows nodular lesion on OCTA, but once you correct with segmentation error, you can see that this lesion disappear, leaving us with this lesion on top of the branching vascular network. And in order to see whether this indeed represents a polypoidal lesion, you can co-locate it with ICG. And here you can see that that lesion co-locate very nicely with this lesion right here. So this is a PCV, which even with ICGA alone, you may not be sure, but if you co-locate with OCTA, you're a lot more certain that you're dealing with a polypoidal lesion. Now, there are many publications of OCTA for the diagnosis of PCV, and in the near future, OCTA and OCT in combination may replace ICGA for the diagnosis of PCV. But we are eagerly waiting for better OCTA hardware and software. Now, about 10 years ago, we have actually argued that the PCV branching vascular network look like and behave like the CNV. Now, this is a case represented in Cambridge Ophthalmology Symposium in 2009, a case with stippled hyperfluorescence, a typical occult CNV on FA, and on ICGA, a very typical CNV vascular structure. Now, who would guess that just a few months ago, this is a patient with PCV, with branching vascular network in the middle. Another case will show you that the branching vascular network, if you co-locate with OCTA, is actually between the RPE and Brooks membrane, looking exactly like type 1 CNV. You see vascular VEGF staining in PCV, a pathological specimen, and there is increased VEGF in the aqueous humor of PCV cases. So it is now widely accepted that PCV is a variant of type 1 CNV with aneurysmal terminal dilatations. Therefore, it is not surprising that PCV cases respond very well to anti-VEGF treatment, very much like a CNV. Now, case in point is a DRAGON study from China, showing that whether it's PCV patients or non-PCV eyes, one can see the same response curve to anti-VEGF monotherapy. However, the patient will require many injections to achieve these excellent results. So typically around 14 injections over 2 years. Likewise, PLANET study, which is mainly a monotherapy study, because most of the patients did not require rescue PDT. In PLANET study, you can see very respectable visual gain over 2 years. However, the polypoidal regression rate is about a third only. However, this patient actually require 13 injections over 2 years. Hence, anti-VEGF monotherapy works well for PCV, which is a variant of type 1 CNV, but require many injections, as the same with CNV. Now, if PCV responds well to anti-VEGF monotherapy, then what's the point of differentiating PCV from CNV? And that's because of the results of EVEREST-2 study. EVEREST-2 is the largest randomized controlled trial for polypoidal choroidal vasculopathy in Asia. Patients are divided into 2 arms, one with combination PDT with ranibizumab, and the other arm with ranibizumab monotherapy. At 24 months, you can see that combination therapy did far better than anti-VEGF monotherapy. The VA improvement curve of combination therapy is consistently better than the anti-VEGF monotherapy over the 24-month study period. The polyp regression rate is far higher, almost double than that of monotherapy arm, with drier macula lower disease activities, and all this requiring only 6 ranibizumab injections over 24 months, or 3 additional injections in addition to the mandatory first three injections. Whereas in monotherapy arm, the patient requires 12 injections on a PRN regimen. And about 2/3 of the patients require either 1 or 2 PDT sessions over 24 months. There's no increase in safety signal, and therefore, while anti-VEGF monotherapy work well for PCV, they require more injections. If you do prompt combination PDT and anti-VEGF therapy, you achieve even better results. You can add about 4 letters to your visual gain. At the same time, reducing the number of injections to around 6 in median and 8 on average. Now, does combination therapy work well with aflibercept? Yes, it does. There's a study that compared combination PDT with ranibizumab versus aflibercept and showed that there's no difference in the visual gain. There's no difference in the CMT. There's no difference in the polyp regression rate, and no difference in the number of injections needed. So combination PDT and aflibercept does work very well as well. There's another study of combination PDT with aflibercept showing that the treatment-free interval is as long as 12.8 months after the initial therapy. In these studies, the patient over 24 months only require 1.5 PDT sessions and 2.9 aflibercept treatments. How about PDT and Avastin? Likewise, PDT and Avastin work very well in combination as well. In this 36-month retrospective study, the patient showed visual improvement of 10 letters, requiring PDT of 1.4 sessions and about 3 Avastin injections per year. Now, meta-analysis also showed that polyp regression rate is far higher among PDT in combination with anti-VEGF monotherapy. I beg your pardon. The polyp regression rate is far higher in PDT in combination with anti-VEGF compared to anti-VEGF monotherapy. And in real-world data, the visual gain achieved by combination therapy is sustained over 3 years in this study. And in an even larger real-world study, Kevin Teo has shown that if you combine PDT with anti-VEGF therapy, any of the anti-VEGF therapy pulled together, you have an improvement of 16.9 letters compared to improvement of 8.2 letters if you use monotherapy alone in real world. The proportion of inactivity is higher in a combination group. The time to quiescence, that means the time you take to reach quiescence, is longer in a monotherapy, and the number of injection in combo is again fewer compared to mono. Now, is polypoidal lesion regression that important? Now, there's a study that looked at 233 patients with PCV and measured the number of submacular hemorrhage episodes over more than 9 years. And this study found that if you achieve polyp regression after the initial treatment, your chance of getting an episode of submac hemorrhage over the first 3 years is only 1/6 that of the other group of patients that did not achieve polyp regression. And over 9 years, you find that the risk of having submac hemorrhage is only 1/3 of the group that did not achieve polyp regression. Now, looking at another way, if you can achieve polyp regression after the initial therapy, you reduce the risk of submac hemorrhage by almost 3/4. Now, hence, in patients with symptomatic macular PCV, prompt combination PDT with anti-VEGF therapy should be considered Longer-acting anti-VEGF agents on longer fixed regimen may eventually provide viable options in the near future. Now, what are some perceived disadvantages of PDT that affected the uptake of PDT among specialists? One is capillaris ischemia after multiple PDTs. And these typically occurred in PDT monotherapy for AMD CNV in the late 90s and early 2000s, because at that time there was no anti-VEGF treatment. And so the only treatment is PDT, and patients require multiple PDTs, typically around 5 over 2 years. And Ursula Smith has shown that after 4 full dose PDT over the macula, over the fovea, a person could get irreversible choroidal capillaries damage. And therefore, if you can avoid the fovea for your PDT, the second is that there are cases of acute exudative response following PDT if the lesion is large and the baseline vision is good. So in those cases, do consider half fluence or reduced fluence PDT. Now, some examples. This is a patient with serous maculopathy. The PCV lesion is right here. Now, it's important not to PDT the whole lesion, but only PDT over the polypoidal lesions right here, thereby avoiding the fovea. This is another example of PCV patient with a large but quiescent branching vascular network, and the leakage causing the serous PD actually come from this giant polyp right here. Now, if you co-locate with OCT, you can see that branching vascular network is actually not leaking. And therefore, one should not PDT the branching vascular network that is inactive. Rather, we should hone down the treatment zone to just the troublemaker, in this case, the polypoidal lesion. And this patient, after several sessions of PDT on just this little area, the patients achieved quiescence and remained so for the subsequent 9 years. I last saw the patient just a few months ago, and is still quiet. And therefore, multimodal imaging guided PDT is important to achieve the result we see in Everest 2 study. Key point, avoid irradiating the fovea as possible and avoid irradiating quiescence BVN. If you wish to irradiate over BVN that's leaking slightly, do consider reduced fluent PDT. Now, in summary, PCV is best understood as an aneurysmal variant of type 1 CNV. Leakage can come from the polypoidal lesion or the branching vascular network. Treatment should aim to treat over the leakage causing part of the lesion, or active lesion only PDT. The gold standard of diagnosis of PCV is still based on ICG at this moment, but we eagerly await better OCTA machines that will help us provide non-invasive diagnosis of PCV. Prompt combination PDT and anti-VEGF should be considered for the treatment of PCV because it should achieve better BCVA, higher polypoidal lesion regression, higher proportion of quiescence, longer disease-free interval, fewer injections that average only 1 or 2 PDT in 2 years, and possibly less frequent rebleed. And do consider multimodal imaging guided PDT targeting active lesions as recommended in Everest 2 treatment and retreatment protocol. I'd like to acknowledge our Everest 1 and 2 study group colleagues, and also many people whom I've learned a lot from, including Professor Yuzawa, Colin, my colleague, Giovanni Soranghi from Milan, Italy, Ethan Priel on the imaging and imaging standard, and Professor Neil Brestas on setting up the diagnostic criteria. With this, terima kasih.